So welcome everybody to this noon symposium on vitamin K-dependent carboxylation of MGP. I'm Jürgen Flöger, I'm from Aachen, Germany, and my co-chairman is Etienne Cavalier from Liège. He's like 50 kilometers west of me. I'm really amazed to see so many faces in here. This is a good sign. So we'll do a first little survey. Who of you knows what natto is? Who has eaten it? Who liked it? Okay, we have a clear vote. So there were 60 hands for knowing natto, 20 have eaten it, 1, I think, liked it. So we need to find out how to improve that, and the first speaker will be Ziad Massy. He will talk about vascular calcification in CKD patients. Ziad is from the Paris West University, and he also still has an appointment in Amiens, where his INSERM was and his previous life was. He's an EDTA council member, and Ziad has published very extensively on vascular calcification, and will tell us everything he knows on pathophysiology and clinical manifestations. Ziad.
Yeah, thank you, Jürgen. Thanks for the organization and IDS to invite me. And we don't have time in 25 minutes to speak about everything in vascular calcification. So I select for you some of the area and the point I would like to share with you. And I will not speak about vitamin K or MGP, and we have two eminent speakers who will speak about that later on. Why we should take care about the vascular calcification? Vascular calcification is frequent in CKD patients. This is one of our cohort in CKD 2 and 3, 4 and 5, and 5D. As you can see here, whatever the method to quantify the calcification, it's progressing when the CKD progress. Not only for that, but all this calcification are predictive of mortality. If you have calcification, you have high overall mortality and cardiovascular mortality. Again, you don't need to have CT scan, just X-ray with aortic calcification, and you can get, this is a positive increase of mortality. And everyone will ask what the adding value to have this determination of calcification. And we ask ourselves, and we did in the same cohort, different method of evaluation of vascular abnormality like intima media thickness, pulse wave visibility, and aortic calcification. The only parameters who add to Framingham parameters to predict, to ameliorate the prediction was aortic calcification or coronary calcification. So if someone asks you what the adding value of vascular calcification, you can tell them that yes, we can use them to ameliorate the prediction of cardiovascular complication. What we don't know yet, but will be matter of discussion, whether the treatment of calcification modulates this mortality, and this is a causality need to be proven. A few years ago, that when we start thinking about the calcification, we learn from the bone, where you have normal process of calcification, that you need to have initial matrix vesicle, and then you have bone formation by osteoblast and bone resorption by osteoclast. What we learned in the vascular calcification in wall, normal wall doesn't have anything of this. If you have calcifying vascular wall, then you will find this matrix vesicle, you will have osteoblast-like cell, and I show you we have some osteoblast-like cell. Matrix vesicle is very important step, and this is has been discussed, and some people call it calciprotein vesicle. And this is very important because they have inside some anti-calcifying product like vitamin A and active matrix protein, and also some microRNA which is modulate the calcification. And when you have a huge production of matrix vesicle or less activity on phagocytosis, then you can come up with increase of calcification outside and this transformation of the cells. This is really the first step of calcification. The second step of calcification is the modulation of smooth muscle cell to be osteoblast-like cells. And here, this is a typical example. When you increase the concentration of phosphate, you have an increase of calcification. It is time-dependent. You can see here that we need to wait until 10 to 14 days, it depends on the model, to reach the maximum of calcification. What we have here is a list, is not exhaustive list, for inducer transforming this vascular smooth muscle cell to osteoblast-like cell capable to produce extracellular matrix, allowing also to apoptotic body and allowing the precipitation of calcium phosphate product. You have here some of the molecules which can block this transformation. It's important to keep in mind vascular calcification is two levels, cellular level and mineral level. You will not have calcification if you don't have this product, and you don't have calcification if you have only the product without the matrix. And how the phosphate can do that, there are a lot of data showing a summary of them. Phosphate go inside the cell by co-transporter sodium phosphate, activate many molecules. In the end, they increase CBF-A1, core binding factor A1. This transcription factor is usually present in osteoblast, which is not present in smooth muscle cells. But when the cells, smooth muscle cells, become osteoblast-like cells, then express this CBF1. And then you have to start to produce this extracellular matrix. The importance of phosphate in the genesis of calcification coming from many type of experiment. I show you one. If you take a mice with FGF23, you knock out the mice, you have an increase of phosphate and increase of vitamin D, and you have huge calcification in the aorta. If you take the same mice and you give them low phosphate diet, as you have prevent the apparition of this calcification. If you do the same with vitamin D, there's no change. So clearly that phosphate is playing a role here to induce the calcification. The other model is similar one, is Cloto, and Cloto, if you knock out Cloto, you come up with a similar phenotype, high phosphate, high vitamin D, a huge calcification. And this model, when the author have a double knockout with the using this co-transporter sodium phosphate, they block the entry of phosphate in this Cloto minus mice, and they have no calcification. So it's clear that phosphate is an inducer, and phosphate is going to induce this transformation of the cells by going through sodium phosphate transporter. Phosphate is not doing only transformation of osteoblast-like cells. Phosphate is participating in a mineral process. But also, we ask ourselves if it's true. If you have an arterial wall, you have this smooth muscle cells become osteoblast-like cells, capable to produce rank L, which is present in the arterial wall, MCSF, and you have a macrophages. Why we should have an osteoclast? This is what happened in the bone. And we try to find this osteoclast in different models. You can find one. This is multinuclear cells capable to produce some enzyme to resorb the bone matrix, but you couldn't find it. So we ask ourselves, what if the phosphate blocks this process? And I will show you here that what happened. If you increase the concentration of phosphate, you decrease the number of osteoclasts, not only the number, but also the function, because here evaluated by number of pits in the plaque, bone plaque. So you have phosphate not pushing to transform the cells, pushing to have bone in the wall, but blocking the process of the resorption. Phosphate is not only a player. You can have many. I show you that one of the important story that when we should start, I mean, if you have chronic kidney disease, you have high phosphate. But in general population, like aging population or diabetic population, you don't have high level of phosphate. And one of the mechanisms which start, it's having cathepsin S degrading the elastin. Elastin fragment do the same thing like phosphate. It can transform smooth muscle cells to be osteoblast-like cells. If you combine phosphate and elastin fragment, you obtain the same osteoblast cells. I don't have time to go through all this pathway is going on. One of them is activin, and activin going through SMAD or MAP kinase and giving you this vascular calcification. And if you block this pathway by giving what we call ligand trap, block activin, and you don't have this activation of bone morphometric protein to induce calcification. You ask me how this bone morphometric protein can induce calcification. We should come back to what we know about CBFA1. CBFA1 have a genetic production and then need to be activated, phosphorylated, linked to AP1 to be active. And BMP, this is bone morphometric protein, is important to induce the production of CBFA1. So this is the way why this is BMP1 to stimulate SMAD1 and SMAD4 and increase the expression of CBF1. Naturally, it's not only inducer. You have the inhibitors. And you will hear later on about activating matrix GLA protein. But I can tell you that Jürgen is present here about the phytrin A. We have a lot of work done with pyrophosphate. We have a lot of work done in calcium sensing receptor. And I don't have time to show you all the data. But keep in mind, calcium sensing receptor is protective against calcification, at least an experimental level. So if you activate calcium sensing receptor, you prevent the calcification. So the question, how to link this, all this story about between bone activity, which is modulated in CKD, calcification, and uremic toxin. One of the hypotheses is uremia is a model for accelerating aging. And if you compare what we have in aging population with normal renal function and uremic patient, you can see that we have an increase of TGF-beta, decrease of autophagy, decrease of Clotho. And I show you, if you have a decrease of Clotho in animal model, you have a huge calcification. So this, again, for autophagy, autophagy is the one way to stop the process of calcification. If you activate this autophagy, you have less calcification. You can see here that we have a decrease. If you block this autophagy, you have an increase of calcification. So we are close of the model of aging. Why I should speak about aging? Because in the literature, you have a disease called Hutchinson-Gilford progeria syndrome, which is really an accelerated aging model. This is a 17-year-old lady. And this is a disease is abnormal, let's say, nuclear membrane. And why they do have this abnormal nuclear membrane? Because the processing of prelamin A is stopped. Instead to have mature lamin A, they have abnormality in this one, and they keep have prelamin A, we call it now progerin 2. So the accumulation of prelamin A lead to destruction of this nucleus membrane and accelerating of aging. And Keep in mind here that the process of pre-laminin A to become lamin A need to be use some enzyme called Farnesyl Transferase, which is necessary to transfer the one product called farnesyl. I will be back in a few minutes. Progerin is present in the aortic calcify and general population independent of CKD. You can see here the presence, and that, if you have double staining, you can see it is in the middle of the nucleus. So it's the accumulation of this progerin is very important for us. And for CKD, we have a good work coming from Catherine Shanahan showing that dialysis patients have an accumulation of prelaminin A, and this accumulation of prelaminin A in dialysis patient is associated with a huge calcification in vivo or ex vivo here and in vitro, and associated with a marker of senescence, this accelerating aging. So the question comes what we should do in this accelerating aging in this population, and whether we should, if we stop this process, we can modify the calcification. And so we can cut this paper published a few years ago, the author treat this patient having this Hutchinson-Gilford progeria by Farnesyl Transferase inhibitor. I show you that's the principle of this drugs. Each cell to survive need to have a mevalonate pathway to produce cholesterol. But before to producing cholesterol, they produce a somewhat intermediate material called isoproenoid, which is a farnesyl, geranyl, and this is very important product to attach some protein to the membrane, like RAS. RAS is molecule here, it's just switching the message from the receptor to the nucleus. If RAS is not attached in the membrane, it's in the cytoplasm, they will have no signal. So it's important to know that this is farnesyl is necessary to attach RAS in the membrane close to the receptor. So if you use this Farnesyl Transferase inhibitor, you block this process, then you have no RAS, you have no attachment in the membrane, you block all this activation. And a few years ago, we looked about serum and mevalonate in our patient, and you can see this more progression of renal disease, you have an increase of mevalonate. And if you have an increase of mevalonate in the plasma, you may have also an increase of farnesyl. We tried to evaluate the farnesyl in our blood cells, but it's very difficult. It's tiny amount, and we use MSMS, we couldn't get it. However, in 2011, this company came to us and asked us if we want to use this Farnesyl Transferase inhibitor to test the model, and we have a model of uremic mice, which when you induce uremia and background of apolipoprotein E, and then you have an acceleration of calcification, and as well as acceleration of atherosclerosis. And you can see here CRF mice, non-treated with calcification, and we treat them by Farnesyl Transferase, and we can see here that this is decrease of calcification. We use this Farnesyl Transferase to examine the mechanism of this effect, and we see that if you treat this mice with this Farnesyl Transferase inhibitor, you decrease the expression of ranks in the aortic wall, and this is related to the modification of this farnesylation of some protein, and this is one of this protein need to be farnesylated, and you see when you inhibit the farnesylation, and you have this non-farnesylated protein increase. We do also some proteomic evaluation in this mice. We found that in CKD mice, you have a decrease of phenytoin, like human, and this drug can modulate, restore the level of phenytoin. Restore also decrease the level of lipoprotein A4, which is a marker of inflammation, and they also decrease the level of alpha globulin, which is a marker of oxidation. You can see here, this is a CKD mice, and this is a CKD mice treated by farnesyl. This means that this drug has a systematic effect to modulate the inflammation, oxidative stress, in our mice. But we tested if this drug has a direct effect in culture cells. If you have smooth muscle cells, you put these cells with phosphate, you have a huge calcification. If you use these same cells with this inhibitor, at dose dependent, you can see that we have a decrease of calcification. And this is certainly going through RAF dependent pathway, because when we use sorafenib, which is an inhibitor of RAF, which is another molecule close to RAS, we get the same thing. And why this drug, in addition to systemic effect, has also a direct effect, it's related to collagen 1. If you put phosphate in culture cell, you increase the production of collagen 1. If you use this farnesyl inhibitor, you have a decrease of collagen 1, and as well as if you use sorafenib. Please remember, we didn't modify in this model neither calcium, or phosphate. We only modify the expression of collagen 1. So it's maybe one way to think differently. If you have a drug can modify the expression of collagen 1, if you can still have hypercalcemia, hyperphosphatemia, but you don't have any calcification because the network of matrix, which is necessary to have this precipitation of calcium phosphate product, is not there. This is work actually published a few years ago by Kersanti group showing that when you have calcification, you need two things. You need the mineralization process, calcium and phosphate, especially phosphate, and this is matrix. And now this is a direct expression. So this is drug can be used to reduce inflammation, oxidative stress, which is closely linked to calcification in a systematic way, as well as have the direct effect in the vascular wall. Do I remember you that we are not so far from this reality? All of you have learned that about this new generation of biphosphonate. Biphosphonate have been used to protect against osteoporosis, but it can be used also to prevent against calcification. And the new generation of biphosphonate is blocking an enzyme, and this is mevalonate pathway, not at the level of what we call Farnesyl Transferase, but at the level of what we call farnesyl synthase. It's the same. Or you block the transfer of farnesyl to RAS, or you decrease the level of farnesyl, but you end up at the same result. Is no farnesyl close to RAS, is no active RAS, and you have block of this process. So it's very important to look about this pathway in the future related to calcification. So I finished what we want to tell you, but I still have a huge thing to discuss with you about how this uremic toxin induce calcification and how this anti-calcifying molecule blocks. I didn't speak about calcium mimetic. I didn't speak about pyrophosphate. I didn't speak about magnesium. And you will hear for long, good talk after my talk with vitamin K2 and matrix GLA protein. But the goal at the end, it's simple. If you wanted to stop the calcification, you need to have to play, or you decrease the inducer, like phosphate, inflammation, oxidative stress, or you increase the inhibitor, or you do both. And if you do that, we have proved that we can stop the progression of calcification, at least at an experimental level, and some data from a human, but we don't have this causality. What happens if you modify this calcification related to cardiovascular mortality or all-cause mortality? Thank you very much for your attention.
Thank you very much, Ziad. We have 5 minutes for questions. So Ziad, can you speculate a little why it seems clinically that once you have calcification, there's no way to get rid of this? Why doesn't it resolve?
I don't have the slide here. It's chemical reaction. If you have calcium in phosphate, you have two steps to have this what hydroxyapatite. You go with amorph crystal first, and then you go to hydroxyapatite. At the level of amorph crystal, it's bidirection. Then you can make crystal, and then you release calcium phosphate. Okay. Once you reach the level of hydroxyapatite, it's no way it's stable forever unless at the bone you have active process, proteases, secretion of H ion to dissolve this one. So we know that we can prevent, after transplantation, for example, we can stabilize the calcification, but we never get, and this is one hypothesis we work on for many years, the role of osteoclast, how to activate osteoclast-like cells in vascular wall, because we know that this is some like phosphate, but we show that it's similar things for sulfate that can block this process. So if you want to regress, you need to have active process, and you need to activate osteoclast cells.
Yes, please.
Thank you for your very clear presentation, Ziad. Just a question, during all the cascade that you showed us on a physiopathological way, is there any role for the parathormone in terms of calcification? Because it didn't not once show it.
Yeah.
Can you just repeat the question?
The question was, what is the role of parathyroid hormone in the calcification? It's very difficult for the role of parathyroid hormone in vivo. Some data from in vitro showing the opposite. If you use a parathyroid hormone, you can prevent calcification. In human, it's each time you have an increase of PTH, you have at the same time modulation of phosphate in calcium. If more, I forget her name, Dr. Rosa Moises from Brazil, they did something that they take the parathyroid hormone out and look about the role of phosphate, and then they took it out, they inject PTH. And then when they inject continuously the PTH, they show they have an increase of calcification. On the other hand, if you take the same animal and you have what we call intermittent injection of PTH, then you have protection of calcification. So it seems that, I should say, if you have a constant increase of PTH, you have an increase, maybe an increase of calcification. But if you, don't have a proof that direct effect of PTH in human, because we have this association PTH calcium phosphate.
Yes, please.
Yeah. Given the central role played by rank and rank ligands in the case, do you think that the novel agent denosumab, by targeting this pathway, could have some beneficial effect?
Yes, certainly. I mean, well, it depends how you, at the cellular level, there could be a deleterious effect because you can block this osteoclast production. But in human, you have this crosstalk between bone and vessel. And if you modulate the bone, and you can decrease the calcification. So probably the balance between the direct effect and non-direct effect, we need more data. I mean, this is true, yeah.
Good. Thank you so much, Ziad.